So who is RRBA? Anyone?
Sorry, it's Roland. I'll change I'll change.
Oh, hi. How are you doing?
Hey, how are you? I'm doing okay, thank you.
And who are the Sunnybrook Fellows? Just so I know your name, so I'm not calling you guys fellows. Put it in the chat or something. All right, let me just share my presentation. You guys can see this okay?
Yes, we can.
Okay, perfect. All right, so first of all, welcome and sorry you stuck with me for 2 hours on this gorgeous day. Hopefully we can wrap up a little bit earlier. So today I'll be talking predominantly about traumatic brain injury. And if time permits, I have some materials on spinal trauma as well. So I don't have any financial or other conflict of interest relevant to this presentation. I do want to thank Alberto, who gave a similar talk a few years ago and allowed me to adapt a few of his slides. So I'll start by reviewing some of the key concepts in TBI management, as well as the Brain Trauma Foundation guidelines that you should be familiar with at this point. And I'll start with what's relevant from the minute the patient shows up in the trauma bay and then transition to more ICU relevant consideration. And in the second half of the talk, um, if we have time, I'll talk about how we can move beyond the guidelines and try to individualize care for our patients a little bit better using neuromonitoring. And please feel free to interrupt at any time or put any questions into the chat. And if I don't see the question, just interrupt me. So just a bit of epidemiology to put things into context. So this is data that was presented in the Lancet Commission on TBI, which published a few years back in 2017. And you can see that in Canada, the incidence is estimated at about 1,000 per 100,000. And if you think about all the other neurological conditions that we commonly treat in the neuro ICU in Toronto, this makes it about 10 times more common than all types of strokes combined, and almost 100 times more common than aneurysmal subarachnoid hemorrhage. So, of course, about 90% of these patients would be so-called mild TBI and may or may not require hospital admission, but there's increasing evidence that even what we currently would classify as mild TBI can lead to quite significant and persistent disability for patients. So breaking down these numbers a little bit more, in Canada, there's about 20,000 hospital admission for TBI per year, which means that about 2% of the population is living with some consequences from a previous TBI, and it is the leading cause of death or disability in young people, costing huge amount of money every year. So 3 billion a year, obviously a really rough estimate. So as you know, we currently classify TBI using the Glasgow Coma Scale, which actually just turned 50 years old this year. And I was just recently at a conference where Graham Teasdale, who sort of came up with this system 50 years ago, sort of gave us the story of how this happened. But it's important to remember that the post-resuscitation GCS is what we really care about, because if you're not perfusing your brain because you're in hemorrhagic shock, then the GCS is really not that informative. Unfortunately, it's also not a great way to classify these patients. It's very non-specific. It tends to underestimate severity of injury in the elderly, where they can accommodate a lot of lesions without necessarily dropping their level of consciousness because of their brain atrophy. And it does also a lot of confounders in the trauma setting, which often make it unreliable. So not only intoxication, but also all the sedative and analgesia that we give the patient as part of our initial management. So there's actually a new proposed framework for classifying TBI in a bit of a more granular way that's coming out of this international panel of experts. And it's really an attempt to have a system that allows us to classify people in a more therapeutically meaningful. And this is not published yet, so you're not going to find this anywhere, but it makes sense. There's no modern disease that we would classify as mild, moderate, or severe. Like you wouldn't classify patients, classify cancer patients this way. There would be no way to treat them. So we need to come up with something, that's a little bit more 21st century worthy. I guess for this specific system, they're dividing it into some clinical components, some biomarkers. So the most promising so far have been GFAP, UCHL1, S100B, and some more advanced imaging features, and then add some modifiers based on the patient premorbid condition and also some social and environmental factors which may contribute to outcome and someone's potential for recovery. So like, for example, here working at St. Mike's, we see a lot of people that don't have any social supports. And we know that these patients, with the same injury, they'll do poorer just by virtue of not having this support to go through rehabilitation. So in terms of TBI pathophysiology, you've probably heard of the terms primary and secondary injury before. So primary injury really refers to the immediate damage that you get from whatever external forces are applied to the brain at the time of injury. So, going through the different types, you can see A is more of a diffuse shear brain type injury, which we often call diffuse or traumatic axonal injury, which you may or may not even see much on the CT scan. But if you were to get an MRI, you could see some white matter damage. Then B is quite, a lot more obvious, where you have all of these bifrontal and temporal contusions, and then C where you have an extraaxial lesion, either an epidural or subdural hematoma, causing a lot of pressure on the brain with some brain shifts. The secondary injury really refers to the delayed neurological damage that you can get from other secondary insults to the brain, and the usual offenders being anything that reduces the supply of oxygen or glucose to the brain, like hypoxia, hypotension, hypoglycemia, or things that increase brain metabolic demands like fever and seizures. Unfortunately, there's very little we can do about the primary injury other than preventing it from happening in the first place through public health measures. So really the mainstay of ICU management of TBI is mitigation of the secondary injury. And this is what we're going to focus on for the rest of this talk. So what does this mean once a patient with a suspected moderate or severe TBI shows up in the trauma base? So if we keep things very simple and go through our primary survey framework, starting with airway, when should we think about securing the airway for these patients? So historically, there has been some controversy about pre-hospital intubation of severe TBI patient is beneficial or not, with some studies showing a benefit, other showing no benefits or even harm. And if you synthesize all the data from the higher quality study, it seems that pre-hospital tracheal intubation is probably beneficial for patients with severe TBI, as long as it's done by someone that's been well trained. And in this recent study from Center TBI, which was one of the largest TBI cohort study that's been recently completed in about 20 European countries, they saw that pre-hospital intubation was associated with a better functional outcome, especially with people with higher thorax injury score, which makes sense. These people are probably prone to hypoxia, hypoventilation, so taking control of their breathing may make more sense at an early stage. And then once the patient reached the hospital, those with the GCS of 10 or less at ED arrival seems to benefit from intubation, which is a bit higher than the traditional, GCS 8 or less intubated we've all learned in medical school. and that guidelines have been sort of referring to for decades. So other than the GCS, which we know is not always a reliable predictor of someone's ability to protect their airway, what are some factors that we want to consider when debating whether or not you should intubate someone? And I think anytime you have difficulty oxygenating or ventilating, you should have a very low threshold to put the breathing tube in. And you should think about doing it so early to avoid secondary injury. Somewhat with clinical signs of brain herniation should be ideally intubated before they reach that stage, but if not, they should be intubated not only for airway protection, but also so you can control their oxygen levels and CO2 levels very tightly. People with severe extracranial injuries that will need ORs, people with severe agitation can be a relative indication if you can get them safely to the CT scanner and et cetera. And then obviously people that need to be transported and you're worried that they're going to deteriorate should definitely have their airway secure before transport. So if you do decide to intubate them, there's a few important points to keep in mind. And there's many different ways to do this depending on the specific scenario, but usually it's done through a rapid sequence intubation. And you always want to think about maintaining cervical spine precaution, usually with inline stabilization. If you are worried about elevated ICP and you already have a CT scan, then you should just raise the head of the bed 30 degrees or so. If you don't have imaging, it's usually safe to at least put the patient in reverse Trendelenburg. And it seems like a silly intervention, but it can make a huge difference. Like studies have shown that you can get 5 to 8 millimeters of mercury difference in your ICP by just doing that, which is huge when you consider how much reduction we get with people with ICP monitors that we're bombarding with hypertonic saline, for example. Like any critically ill patients, you do want to resuscitate before you intubate, and not only systemically with broad products if they need them, but think about giving osmolar agents if you're concerned about ICP. And then, so in general, it's best to stick to what you're comfortable with, but using something like videolaryngoscopy to minimize glottic stimulation makes sense. And then there's really no evidence that pretreatment lidocaine makes a huge difference in terms of blunting the sympathetic response that we typically talk about. And there's also no evidence that a defasciculating dose of neuromuscular blocker is helpful if you're using succinylcholine. I think we've, as intensivists in general, we've moved away from using sucks because now we have a reversal agent for ROC, but I do see it used quite a bit in the trauma bay, which for obviously good reasons. So something to keep in mind. And then the other thing is that once you have your tube in, you do well and dial in your end-tidal CO2 as soon as possible to make sure that you're in the right range, and then correlate that with your ABG also. And then ideally, if you're going to sedate and paralyze your patient for intubation, try as much as possible to get a good neurological exam before you do so, so that you can make treatment decisions accordingly after. So I think it's already enough talking that I've done. So maybe we'll introduce a case here and you guys can pitch in some comments and questions. So this patient was a 37-year-old, very high functioning professional who was jumping in and out of traffic, and he was also jumping on cars. Had a fall. I was obviously in the context of some form of intoxication, and it had decreased LOC and it was brought directly from the scene to our trauma bay. Going through the primary survey, so he came in with a nasal airway. They felt that he was handling his secretion. He had good air entry. He was signing well on room air. He was a bit bradycardic in the mid 40s to 50s. Blood pressure looked reasonable and the EFAS was negative. GCS was E1, V1, M4. He was only moving his left arm, and the pupils were equal and reactive, but he did have this conjugate gaze. And there was some asymmetry and bogginess of his the back of his head that was noted, but there was no open wounds. Labs didn't look too remarkable. Lactate was slightly elevated, and coagulations were within normal limits, including the ROTEM. And then he had an alcohol level of 80. And this is sort of so just trying to remember. So he was GCS 6, as we mentioned, but they felt that his airway reflexes were intact, and he was otherwise hemodynamically stable. So he was transferred to the CT scanner with his nasal airway in place. And this is what you see, and we'll come back to that a bit later. And there was nothing else that was remarkable on the trauma CTs except maybe some signs of aspiration. So just going back here, anyone would have intubated the patient right away before CT scan? Any votes in the chat, maybe? Intubate, do not intubate. Who's here? Let me see if I can see the names. Roland, would you intubate this patient?
Yeah, I think he's beginning to show signs of increased ICP. The primary working impression is he might have a big TBI, and he's having sinus bradycardia. I would have been interested to sedate him and make sure the CT would be safe.
Yeah, I think that's reasonable. Any votes for intubation? Intubate? Okay. So basically, obviously, they didn't intubate up front here, and the patient was brought back to the trauma bay. And after seeing the results of the CT scan and the evidence of aspiration, so just have a quick look at the CT, and we'll come back to that, as I said. So clearly something that's not normal here. They decided that he should get his airway secured, and his GCS was still 6. So they basically gave him 3% a bolus at 3%. They maintained his MAP 80 to 85 with some norepi. They intubated with some etomidate and sucks, and they used visual laryngoscopy with a hyperangulated blade with inline stabilization. And then during induction, he actually brought it down to 20 to 30, but responded to atropine. And it was quite a difficult intubation. The patient had a large tongue and very limited mouth opening. And so the first attempt was esophageal, and then he had some vomiting. They had to suction and do rescue back mask ventilation, but he didn't really desaturate below 90. And then the second attempt was successful. And when they got the tube in, they targeted a end-tidal of 30 to 35, and he was sedated with some propofol and fentanyl. So moving on to breathing, I'm sure you've heard this again and again, and you'll hear again it many times during this talk, but you do want to avoid hypoxia in this patient and at all costs. And you also want to pay close attention to the CO2 levels for a reason that we will go over. So starting with hypoxia, these are data from the Impact TBI project, was now initiated about 20 years ago. In which they performed a big meta-analysis of all the big trials and large prospective studies in TBI with a total sample size of about 10,000 patients. And they saw that patients who had even a single episode of hypoxia, which they define as a PO2 of less than 60, had twice the odds of having an unfavorable outcome. What about CO2? We know that in some cases, hyperventilation may be helpful. So if you're lowering the CO2, you're inducing vasoconstriction, which then leads to a reduction in cerebral blood volume, which in a pinch can be a very effective intervention to decrease ICP. The problem is that the vasoconstriction not only leads to decreased blood volume, cerebral blood volume, but also cerebral blood flow, and therefore oxygen delivery to the brain. So in fact, for every millimeters of mercury reduction in your PaCO2, your cerebral blood flow decreases by roughly 2 to 4%. And we know from PET scan studies, PET cerebral blood flow studies, that the brain is often very oligemic, in the first 24 to 48 hours after TBI, and is therefore very vulnerable to further reduction in its blood supplies. So this is basically what the BTF guidelines say. So, based off sort of on what we've discussed, they say that prophylactically hyperventilating patient is not recommended, and it should only be reserved as a short-term bridge to immediate neurosurgical intervention, basically someone with impending brain herniation. Avoidance, so moving on to circulation, avoidance of hypotension. I think you guys are pretty familiar with this for the most part. So the BTF guidelines say that you should aim for systolic above 100 for patients 50 to 69, and then 110 for everyone else. And this is based on very low to moderate quality evidence, and it seems very arbitrary. There's obviously nothing magical that happens at 50 and then again at 70 years old, but this is what the guidelines say, and you should know them. And then going back to the IMPACT study, hypertension was even worse than hypoxia. So an episode of a systolic less than 90 was associated with twice the odds ratio of a poor outcome after adjusting for things like age, pupils, and GCS motor score. And reinforcing that concept is more recent data published in JAMA from about 4,000 patients enrolled in a pre-hospital study called the EPIC TBI study, where they said that there was almost a linear relationship between the lowest systolic blood pressure in the pre-hospital setting and mortality between 40 and 120 in systolic. And with about every 10 points decrease in the systolic was associated with increase in the systolic was associated with a decrease in odds of dying by about 20%, so quite substantial. And what's even worse than hypotension alone is having both hypoxia and hypotension, and this is pretty old data from the trauma coma data bank in the 1990s, but it's sort of stood the test of time. And if you look at patients who had episodes of combined hypotension and hypoxia, their mortality risk was in the range of 55 to 75%. Moving on to D4 disability, what can be done early to prevent hematoma expansion? So what about TXA? It seems like we're giving TXA to everyone nowadays, at least in the OR we are. Their conclusion, so these are the conclusions from the CRAST-3 trial, in which they gave a 1 gram loading dose of TXA, followed by a 1 gram infusion in TBI patients with a GCS of 12 or less, so moderate and severe. But they also included mild TBI if they had any intracranial bleeding on their admission CT scan. And overall, they didn't see any mortality benefits for all comers with TBI, so 18.5 versus 19.8%. But there was a borderline benefit when they excluded people who were GCS3 or had bilateral unreactive pupils, because we know these patients are not going to be well for the most part. There was also a benefit in mild to moderate TBI that was highly time dependent. So the sooner within 3 hours of injury that they got the TXA, the better. Shortly after that, there was another big American trials, which I'm not showing here. And in this meta-analysis, they sort of summarize the results of these big studies. Overall, there's no mortality or disability benefit. There seems to be signal toward decreased hematoma expansion, but at least there was no increase in adverse events. And despite that, the 2023 NICE guidelines, which are sort of very well respected in the UK, are still recommending to give 2 grams of TXA upfront in patients with GCS 12 or less. And this was sort of based on a reanalysis of all the individual patient data in these studies, where they saw a benefit when looking specifically at high-income countries. And the bottom line is that there's probably a benefit, but it's probably small. And you should probably give it to moderate TBIs, people with mild bleeding on their skin, severe TBI if their pupils are reactive. If you give it, you should give it as soon as possible. And if they're a polytrauma patient, then you should just give them TXA according to the general trauma recommendation. So probably more important than giving TXA is to examine your patient well and try to identify clinical signs of increased ICP or herniation syndrome. And you've probably seen diagram like this at some point during med school. So there are different types of cerebral herniation syndrome, depending on which part of the brain shifts in which direction, but the most common in the trauma setting being on-call or otherwise called transtentorial herniation, where you have a unilateral mass lesion, usually a subdural or epidural hematoma that pushes against the temporal lobe, and then that translates into pressure in the midbrain, which can progress to tonsillar herniation if it's not quickly identified and addressed. And all of these herniation syndrome have slightly different clinical presentation and progression over time, but for all intents and purposes, they can be simplified into these key clinical findings. So if you have dilated and or non-reactive pupils or pupillary symmetry, it's concerning. If your patient is posturing, meaning their motor exam, they're either not doing anything or they're extending, that's concerning. If they have a Cushing's response, so bradycardia, wide pulse pressure, irregular respiration, that's concerning. And then obviously, if they have a progressive decline in their GCS, then you should also be very concerned. If you are concerned that your patient has one of these syndromes, which osmolotherapy should reach out for them, is it hypertonic or mannitol? Unfortunately, the BTF guideline really are not that useful regarding that. And, I really dislike how they presented their summary of their recommendations. So they basically list recommendation from the prior edition that are not supported by evidence meeting current standards, and then they list the previous recommendations. So if you really don't pay too much attention, like if you're a little bit ADD like me and just read this, you think that those are recommended when in fact they're not. But if you go through the full document, they say that although hyperosmolar therapy may lower ICP, there's insufficient evidence, blah, 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 to make a recommendation. So basically, you're not really giving a recommendation. So there's a number of studies that look at this, including some small RCTs, some of which came after these guidelines were published. And in this systematic review and meta-analysis, there are no difference on ICP in the short term, although it seems that hypertonic saline has a bit more of a sustained effect. And it also did not translate into any functional outcome benefit. That said, there's a number of theoretical benefits. I think that push many of us to reach for the hypertonic saline first in this context. And the most relevant is probably that mannitol is a diuretic, as you know. So you probably don't want to give a diuretic to someone who is in shock from their splenic injury or hypotensive from the tension pneumothorax. One other theoretical concern is that something called the reflection coefficient, I guess the blood-brain barrier of mannitol, which means basically its ability to traverse the blood-brain barrier is less than 1. So some of it gets into the brain, especially if the brain's injured, and it can lead to rebound edema if you give too much. And that's especially true in patients with renal failure because it tends to accumulate in their bloodstream. There's also some logistical considerations. So hypertonic saline, you can safely give 3% to an IV if it's a good IV, but anything higher probably need the central line. Mannitol can be given peripherally, but you do need a filter because it can form some crystals that you obviously don't want to get into the circulation. So based on what we discussed, unlike the Brain Trauma Foundation, the Neurocritical Care Society does recommend using hypertonic saline first and only using mannitol as a second line in these patients. But there are obviously some reason to use mannitol, later on during their course if they're becoming severely hypernatremic or volume overloaded or the hypertonic saline is just not working. Sometimes it's worth giving it a shot. What about steroids? It sounds like it could be a good idea. We pretty much give steroids for everything in critical care. If you've rotated through TGH, you probably heard Eddie Fan tells you that, critical care should be summarized in a textbook that's divided into steroid responsive and steroid non-responsive disease. And you know, these patients often have contusion, they have a lot of brain swelling, they have mostly cytotoxic, but also vasogenic edema from their blood-brain barrier injury. So, you know, why not steroids? But unfortunately, not only it doesn't work, but there was a big RCT, which is the first of the crash trials that was published in the early 2000s, but that it actually increases mortality in this patient. And based on that, the Brain Trauma Foundation recommend against you know, using steroids in this patient. And in fact, this is the only level 1 recommendation in the whole guideline document. But I think one thing worth mentioning that people don't realize is that if you actually read the paper a little bit more closely, they used a loading dose of 2 grams, not milligrams, 2 grams of methylprednisone followed by an infusion of 0.4 grams per hour over 48 hours, which adds up to 21.2 grams, if I can do grade 2 math correctly. And basically this dose was chosen based on preclinical models showing that, you know, it's how much you needed to inhibit the inflammation cascade in the brain. And if you convert this into dex, because I'm a simple dumb neurosurgeon, I use dex, so methylprednisone doesn't mean much for me. It translates into 4,000 milligrams of dexamethasone, which gave me an error message when I tried to put it into MD-Calc saying that I should, you know, very high double check. So one thing to keep in mind, it may be that lower doses have some benefit because these seem like very crazy high doses to me. And the elephant below has absolutely nothing to do with steroids and TBI. But when I got this error message, it reminded me of the very sad story of Tusco the elephant, which you may have heard about, who was giving LSD as part of an experiment back in the 1960s and unfortunately passed away as a result. And in the aftermath, they realized that they had miscalculated the dose and given the elephant about 30 times the dose that a human would take on a per kilogram basis. And you know, in our day and age, you'd probably go to prison for that. But back then, they managed to get a publications in science out of this. So good for them, I guess. Bad for the elephant. So moving on to E or exposure, you know, like in other neurocortical care scenarios, you would want to target normothermia. And this is what the guidelines say. So early short-term prophylactic hyperthermia is not recommended to improve outcomes. And there's 2 big trials that have looked at the role of hyperthermia in TBI, both as an early prophylactic sort of neuroprotective measure, and this was the POLAR study, and there was another trial called Eurotherm on the right side, which looked at using it as a treatment for a subset of patients with increased ICP, and there was no benefit of either approach. I think one big caveat to that Eurotherm trial is that they allowed to cool down people down to 32 degrees. And they used it very early as a tier 2 intervention rather than a tier 3. And there are some leading centers will still use mild hypothermia in the 35 degrees or so range for patient a little bit later in the game where they start having refractory ICP. And the argument is that it actually works really well at controlling ICP, and the side effects, if well managed, are less than alternatives like a big decompressive cranectomy or barbiturates. Imaging, because we're in Canada, you should probably know about the Canadian CT rule, but you know, this is really meant for minor head trauma. So I think it's useful you're working in the ER, but not for the average patient that comes to the trauma bay where essentially everyone should be getting a head CT. I mean, unless they've had a stab wound to the leg, then maybe you don't need to get a head CT. But otherwise, they probably should get one. I think where there's a bit more controversy is who should get a CT angiogram. And everyone seems to be getting one nowadays, and everyone gets, you know, possible grade 1 BCDI. But that said, there's some scenarios where I think it's more important to think about getting vascular imaging. And I'm not gonna go through all of the indications, but they're listed here for your reference. And historically, it was felt that only high-risk cervical spine injury, like if you have an injury at the C1, C2 vertebrae, or the transverse foramen where the vertebral artery travels, then you should get a CTA. But now the East Trauma Foundation conditionally recommends even getting a CTA for lower risk spinal injury based on low quality evidence, but there's some evidence that you may miss. BCVI even with more minor trauma to the cervical spine. So you take the patient to the CT scanner, you see a big bright spot somewhere inside the head. When should you call your neurosurgery friend? Alzina will all very nice and happy to help all the time. Well, we probably should be involved with all the moderate and severe TBI, but there's some patients that we need life-saving surgery and need to be seen right away. So essentially, anytime there's a lesion causing significant mass effect, and that's associated with neurological decline, it probably needs to come out. And the cutoff is generally around 1 centimeter of thickness and 5 millimeter of midline shift for subdural hematoma, and probably a bit bigger for epidural hematoma. And this is not a hard and fast rule, obviously. We do tend not to operate on contusions in the trauma setting unless they're very large and causing herniation, because most of that brain is already severely damaged and you're not going to reverse that with surgery, but you may release pressure on a brain that's still viable if the hematoma is very, very large. Cerebellar bleeds, are quite rare in trauma. Most of them are from spontaneous or hypertensive bleeds, but these patients can get in trouble very early from obstructive hydrocephalus, so we do need to know about them early. And then skull fracture, we usually are a little bit more worried if they are open and they're significantly depressed. And even if your patient doesn't have any of those things, but their DCS is 8 or less, especially if they have any abnormality on their CT scan, then we should probably think about bringing an ICP monitor. So going back to the case, so the patient, last time we, were chatting about it, was intubated, and then you're reviewing the CT. Anything here? Should this patient get surgery? No surgery? Based on what I just told you. So there's a sizable extraaxial hematoma, probably a combination of subdural, epidural. There's also some in the midline in the interhemispheric fissure. And you can see that he has quite substantial skull fractures that are depressed. So it seems that you may have indication for surgery. I think, but like I said, there's no hard and fast rule in here. The problem was that we felt that the extraaxial bleeding was probably as a result of a injury to one of the venous sinuses. So one of the big venous sinuses that runs into the midline called the superior sagittal sinus. So the concern was that if we were to go in and decompress that, the patient would probably bleed to death because you can lose a lot of blood from a big sinus injury. So we opted to treat the patient non-surgically, at least initially. That said, he did need the indication for an ICP monitor because it was a severe TBI with a GCS of 8 or less with an abnormal CT scan. So this is sort of a transition from the trauma ward to the teen ICU. And there he had a ICP monitor and a brain tissue oxygen monitor inserted at the bedside. And clearly, that this picture was staged for an article because we never have empty beds in teen ICU. And B, Alberto is usually a bit more smiley, and I've never seen him wear a lab coat before. Okay, so moving on to ICU, and please do feel free to interrupt me because I realize I've been talking for a lot. I'm even boring myself. So let me just pull up the chat to see if there's any questions, but I didn't see any pop up. Any questions? No questions? Super clear. All right. So I'll keep going. So ICP monitoring, why is it a good idea to stick something into a brain that's already injured? Wouldn't that just cause more damage? Well, I mean, there's been a lot of studies looking at this actually. And if you look at the only randomized controlled trial, which was called the Best Strip trial, which was done in 2012, which compared an approach using an ICP monitor versus clinical exam and serial CT alone, there really was no mortality or functional outcome benefit. That's the sample size was quite small. And interestingly, the patient with an ICP monitor received about half of the number of ICP lowering interventions compared to the group that was monitored with clinical exam and serial imaging. So part of the benefit of having them maybe that reassure the clinicians that things are okay and you don't need to empirically treat ICP. And that said, the trial has also been heavily criticized. First, it wasn't really powered enough, and that's why they used this strange composite outcome. But I think really one of the big limitation, it was done in Bolivia and Ecuador in centers with no previous experience with these devices, and where none of the patients who were enrolled into the study ended up getting rehabilitation, which we know is such a huge part into getting better after TBI. So it's really unclear how this applies to places like here where ICP monitoring has been used as part of the standard of care for decades now. So despite this trial being negative, ICP monitoring is still recommended to reduce short-term mortality, at least in the latest edition of the BTF guideline. And this is based on fairly extensive observational data showing a mortality benefit, including this study of about 10,000 patients from a big trauma database in the US, where it looks like centers who use ICP monitoring routinely had much better lower mortality, even after correcting for all the obvious confounding variables. And this is a more recent study in Europe called the Synapse ICU study, where they saw lower mortality and better neurological outcomes in TBI patients in which ICP monitor was monitored, at least if they had at least one reactive pupil. So which ICP number should we be shooting for? Is it ICP of 22, which is what is recommended in the Brain Trauma Foundation guideline? Why 22 instead of 20 or 25? Once again, there's really nothing magical that happens at 22. And if you really dig a bit deeper, that was only derived from a single retrospective study of about 440 patients. And there's a number of other observational studies, most of which are also retrospective, unfortunately, suggest that the cutoff may be around 19 or 20. For example, this high resolution study where they look at 500 patients. But it's probably more important to look at overall trends rather than a single number. And there's evidence that even lower levels of ICP, if they're sustained for prolonged periods of time, can be quite detrimental. And this is a paper that's been, quoted over and over again, where the authors came up with the concept of ICP time burden or ICP dose. And in their analysis, even an ICP of 15, if it's sustained for a prolonged period of time here over 3.5 hours or so, was associated with worse outcome. So if the ICP of your patient is sitting at 21, it probably doesn't mean that you should tap yourself on the shoulder and go have a coffee. There's other things you can do to figure out whether you should be treating this. And we'll talk about some of those things. And for those who've been through our unit in the TNICU, you've probably seen the new ICP monitor called the Sterling, which is sort of the updated version of the Common. And now it will actually display the total ICP dose and ICP burden, which I think as clinicians, we don't have a strong intuition for what that number means in terms of the absolute number. But I think we will develop it as we start using it more and more. And also, it does give you an important information about the trend. So if you see that the dose has been going up for the last few days, then you may not want to back up on the sedation and analgesia and start to wake up the patient. So I think it is somewhat useful. So we also know that ICP is a lot more than just a number, and looking at the waveform itself, like, looking at ventilator waveform, which I know all of us are sort of, at least I was sort of terrorized with when I was starting my ICU training. It can provide you with a lot of valuable information. For example, if you look at the curve at the bottom, you could have a patient with a normal ICP, but where the second waveform called P2 is greater than P1, which is thought to be associated with reduced compliance. And there's, I think, a lot of what we do in the ICU setting is from taking that patient to sort of a point of decompensation where brain compliance is really low, and shift them back to an area of normal compliance. Basically, you want to do everything to optimize them before they compensate, because often it's a little bit too late at that stage. So, next time you see an ICP monitor or someone with an EVD that's clamped, and you run on them, try to look at those waveforms and see whether they have like quite a normal waveform like this, or if it's sort of trying to blunt, or if the P2 is greater than P1, which is probably someone you should be quite concerned about. Even if the number is 15, I would pay a lot of attention to that patient. So obviously it's not the monitor itself that improves the outcome, but it's what you do in response to the information it gives you. And this is a protocol called the CBIP protocol for managing patients with an ICP monitor, which I think is a must read for anyone taking care of these patients. And this is what the ICP management protocol based in our unit is based on. I'm not going to go through everything in detail, but basically the key principle is that you do want to start with the least invasive therapies and the therapies with the fewer side effects, such as analgesia, sedation, normalizing your PaCO2. And then if they don't respond, you want to gradually escalate to more risk intervention, like osmolar therapy, neuromuscular blockade, asking the neurosurgeon to put an EVD in and drain some CSF. And I think it's also useful to think about the physiology that's driving the elevated ICP for the specific patient in front of you, and address that first and foremost. For example, you can do a map challenge where we'll talk about to figure out whether the brain is getting too much blood or too little. If there's a mass lesion, then the patient needs surgery. If it's edema, then you don't want to be very careful with your sodium target. Make sure they're not being bombarded with fluids. And they have hydro, which is rare in the acute TBI setting, but it can happen. Then they need an EVD. And if it's a venous outflow problem, then make sure their head is midline, that they don't have a big clot in their jugular vein or something of that nature. So once you've exhausted, most of the options and the ICP is still high, who if anyone, should have part of their skull removed through a decompressive craniectomy. And there's essentially two ways to do this. One is through a big unilateral craniectomy. Usually we do that if there's a focal pathology on one side. If you have more diffuse swelling, you may want to do something called a bifrontal craniectomy, but it is associated with more complications because you have to go through the frontal sinus, which can cause some infections, and also the big sagittal sinus that runs in the middle, which we talked about before, which is at risk. So typically we prefer to do the unilateral one, but in some cases it may make more sense to do the bifrontal. And this is sort of what the unilateral approach looks like in the OR. And a lot of the ICP reduction comes from opening the dura, and not just taking the bone off. So you do want to make sure that's open really widely. And the next question is, what's the evidence for doing this? And should we do it as soon as the ICP becomes a problem? Or based on what we've discussed, should we want to try the less invasive interventions first? So the early approach, so doing it early, was tested in a trial called DECRA. And they basically took the bone off if the patient had increased ICP for 15 to 20 minutes, 15 to 20 minutes above 20 millimeter of mercury. And it did make the ICP better, as you would expect, but the outcomes were actually worse. So doing it, almost prophylactically doesn't help. And then there's another thing called a primary decompressive cranectomy, where you go in and you remove a big subdural, and then the brain doesn't look too swollen, and you're not sure whether you should put the bone back or not. But basically, there doesn't seem to be a benefit of leaving the bone off unless there's a strong reason in the OR to do so. So basically, it leaves us with only one indication, which is the last year rescue therapy. So using it when the ICP has been a problem for a prolonged period of time, otherwise, known as a secondary decompressive or late secondary decompressive cranectomy. And that means that you've tried tier 1 and tier 2, you've tried sedation, analgesia, maybe some CSF drainage. The patient has been bombarded with hypertonic and their sodium is 160. And despite that, their ICP is still high, then it may make sense. And this was tested in the rescue ICP trial. And as you can see, there was quite a substantial reduction in mortality. So from 52% in the control group down to about 30% in patients who had their bone flap removed. But I guess the main question is, how do the additional survivors do? And there's now been a 12-month and a 2-year follow-up of these patients that's been published. And if you really break it down, basically a third of the patient will die in the cranectomy group. A third will survive with a poor outcome. And a third will have a good outcome. So just Glasgow outcome scale of extended of 5 to 8. And so I think it really comes down to having a discussion with the family and the substitute decision maker, and figure out what quality of life is acceptable to them, and what time frame or day is reasonable for the patient to go through rehab to get to that endpoint. So based on this evidence, there was a 2020 update to the BTF guideline that was published, saying that secondary decompressive cranectomy is recommended for late but not early intracranial hypertension to improve mortality and favorable outcomes. And it also reduces ICP, as you would expect, and ICU stay. But as we discussed, just because it's recommended doesn't mean that everyone should get it. And I think it really needs to be an individualized discussion with the patient and their family. Well, usually the family, obviously, because the patient cannot really participate. So I think I've been talking for almost 1 hour. So I'm going to stop here. Ask there's any question, and then maybe we can take like a 5 to 10 minute break and move on to the next part, which I'm biased, but I think is a lot more interesting, where we'll talk about monitoring and how we can individualize treatment for a patient, try to move a little bit beyond what the current guidelines say. Who is still here and who's ditched me to go enjoy the nice weather? So, okay, still a few people. Okay, so how about we come back at, what time is it now? 3 p.m. Let's say 3:07. Simon, are you still here? I'll message him. All right, maybe we'll get started again so we can finish on time. I did a little bit before. So we've gone over, let me make sure I'm unmuted. Okay. We've gone over most of the key guidelines, and taking a step back, I think the guidelines are useful. They've helped establish a basic standard and protocolize care to some extent. And, some of the data suggest that there's been a reduction in mortality as a result. But I think one of the main reasons we really haven't made that much progress in terms of improving outcomes in these patients relates to the fact that we've been applying this one-size-fits-all approach to all patients, regardless of their demographics, their mechanism of injury, and their injury pattern. And part of it relates to not having a very good classification system, as we alluded to sort of separate patients into more clinically meaningful subgroups. So, for example, if you have an 84-year-old lady who has an acute subdural from a fall from standing height on a Pixaban, it's a very different injury and potential for recovery than a 20-year-old with diffuse injury from a motorcycle accident. Yet, according to the guidelines, basically these patients should essentially be treating the same way, at least from an ICU perspective. So I do want to take the last few minutes to talk a little bit about how we can achieve a little bit more precision in our approach. So if we go back to the guidelines for 1 second and we look at the CPP recommendation, they state that, whether 60, typically, as you know, we target between 60 and 70, but whether 60 or 70 is the minimum optimal CPP threshold is unclear and may depend upon the autoregulatory status of the patient. So, what exactly does this mean, and how do you go about finding out if the patient is autoregulating or not, and use that information to inform your cerebral perfusion pressure targets? So, you may remember from med school that cerebral autoregulation refers to the ability of the brain vasculature under normal circumstances to either vasodilate if the BP is too low, or vasoconstrict if it's too high, to maintain a constant blood flow. But we know that in TBI, this is often quite impaired, meaning that even the most modest degree of hypotension can lead to brain ischemia, and modest degree of hypertension can lead to edema and intracranial hypertension. And so one way to figure this out at the bedside is to do something called a MAP challenge, and you may or may not have seen this done through irritation in some of the neuro ICUs, but basically you take your patient, you record their ICP, their mean arterial pressure, their CPP, you titrate the blood pressure by about 10 for about 20 minutes, and you look at what happens between all these parameters. And if the ICP goes up as you up titrate the MAP or the CPP, this suggests that your autoregulation is preserved to some extent. On the other hand, if the ICP goes up as the blood pressure goes up, then it suggests that it's passively being transmitted to your brain and that your patient is probably not auto-regulating well, at least in that blood pressure range. So I think one of the problems with that approach is that autoregulation is a very dynamic thing in early in TBI, so we can fluctuate a lot early on, especially in the first 24 to 48 hours. And it's also not practical to be standing at the bedside multiple times a day trying to do this. You're not going to make friends with your nurses, and it also introduces a risk of iatrogenic injury, because if the patient is not autoregulating and you drive their blood pressure up, then they may not be able to compensate properly. So there's a better, more elegant way to do this continuously using some special software, and there's different software available. The one that I'm familiar with from spending time with the group in Cambridge is called ICM Plus, and basically probably the most used in this or index of autoregulation, it's something called the pressure reactivity index. And really all of this is the continuous correlation between your mean arterial pressure and your ICP. So if it's positive, meaning that as your MAP goes up, your ICP goes up, then as we just discussed, the patient is not autoregulating. So positive is bad. The lower the number, or even better, negative, means that as the MAP goes up, ICP goes down. Negative correlation, good. And these are sort of the range that in the literature have been associated with mortality and outcome. Obviously, you don't need to memorize those, but just to give you a ballpark understanding. And, if we really want to take this one step further, most importantly, it can be used to individualize your CPP targets. And so basically, if you target the CPP at which that number, the PRX, is the most negative, you should be within a safe range. In other words, if you target the CPP range over which autoregulation is preserved, and this has been termed optimal cerebral perfusion pressure, or CPP opt. So for this patient, it's tiny, but you can see that CPP up for this patient is closer to 75. So higher than we would, actually, never mind, there's two curves. The one on the left, it's closer to 67, 70. So probably on the higher range of the range that we would normally target. And there is observational data showing that deviation from this optimal CPP is associated with worse outcome. And then the Cambridge group recently published the result of a phase 2 randomized trial looking at this hypothesis, and they showed that, it was a phase 2 trial, so they showed that it was safe and feasible, but obviously we need more studies to see whether this improves outcome. In this small sample of patients, it was associated with a benefit, but obviously not powered to detect differences in functional outcomes at this stage. So far we've talked about ICP, we've talked about pressure autoregulation, both of which are primarily concerned with cerebral blood flow. But if the blood flow that's getting to the brain is not carrying oxygen, then it's not really that helpful. And what the neuron really cares at the end of the day is how much oxygen delivery it's getting. So what about measuring brain oxygenation directly? So basic, physiological principle tells us that the delivery of oxygen depends on the cerebral blood flow and the arterial oxygen content of blood, which in turn depend on your hemoglobin, on your O2 saturation, and to a lesser degree on your partial pressure of O2 that's dissolved in the blood. So targeting these variables may represent a way to optimize oxygen delivery. Whereas things that affect O2 consumption can, also be, acted upon. So think that this would be things like seizure, fevers, and your level of sedation, all of which can influence your rate of oxygen consumption inside the brain. So traditionally, we've tried to assess the balance between oxygen supply and consumption in the brain using something called jugular bulb oximetry. And some of you may have seen this in some centers, but it's largely fallen out of favor in most places because it's really not that easy to accurately place. And so there's a lot of issues with misplacement that results in inaccurate values. So it's been increasingly replaced with something called a brain tissue oxygen tension monitors, which are probes that are placed directly into the brain alongside the ICP monitor usually. And sort of focusing on the Lycox probe, which is the most commonly used, and what we are using here in the TNICU. It basically measured the partial pressure of oxygen in a very small region of white matter surrounding the tip of the probe. So it's a very regional measurement, and it's thought to reflect the balance between regional O2 supply and cellular O2 consumption, although there is still some debate about what exactly the number represents. And we know that based on observational data that the values less than 20 probably indicate brain hypoxia and are associated with worse outcome. So it's easy to remember, ICP more than 20 bad, brain tissue oxygenation less than 20 bad. There are a number of pitfalls with these probes. So as I said, it's a very focal regional monitor, so it may not represent what's happening elsewhere in the brain. So the insertion site is very important, and you do want to confirm placement with a CT scan before acting on the value, because if the probe is right in the middle of big clot, you're going to get a low reading no matter what you do. And the last thing you want to do is crank up the FI2 to 100 because your PB2 is low if it's not reliable. So people started using this technology back in the early 2000s, and this is one of the very early papers showing that brain hypoxia was associated with outcome independently of intracranial hypertension and low CPP. And if you look at the numbers in that table, you see that up to a third of the patient with normal ICP and CPP had brain hypoxia, so quite a substantial proportion. And this was associated with worse outcome, as you would expect, regardless of whether the ICP was higher. And as a result, over the last 10 years, there's been a lot of studies looking at this. And in this meta-analysis of all the studies, there seems to be, a benefit of using both monitors as opposed to just an ICP monitor. But obviously, this came mostly from observational studies so far, or at least small single center randomized study. So this has motivated some large multi-center randomized trials, and this is the phase 2 protocol that was the protocol that was tested in a phase 2 trial, and showed that it was safe and probably reduced the proportion of patient with brain hypoxia. And currently this is being tested in 2 large phase 3 RCTs. So Boost 3, which is the one in North America, which we are part of here at St. Mike's, and then Bonanza, which is the sort of Australian, New Zealand equivalent. And there obviously is a plan to combine the results of both trials to, gain a little bit more power and insight. So I show you the CIBIC protocol for ICP only, but what about patients with both probes? So there is also a protocol available for that. And, for those of us using it, so probably you're most likely to see this here at St. Mike's or at Sunnybrook. I think this is a very useful reference. So basically dividing the patient into 4 categories. So, oxygen is okay, ICP is okay, oxygen is bad, ICP is okay, and vice versa, and tells you what intervention you should be thinking of. I think just a word of caution about hyperoxygenating our patient, because there's been a few trials in the general ICU population that showed that while normoxia is associated with better outcomes, if you're deliberately targeting hyperoxia, then you can get into trouble. And so cranking the ventilator to a high FI2 may not always be the answer if the PB2 is high. And you may want to try other things like optimizing your CPP, targeting a lower ICP, ensuring that your CO2 is within the range that you want. And then you can increase the FI2, but only use the lowest amount of oxygen that you need to achieve your target. So another approach to increase oxygen delivery to the brain that doesn't really rely on increasing FiO2, but maybe to augment, the oxygen carrying capacity of blood by targeting a higher hemoglobin target. And this was just actually tested over the last couple of years through a big randomized trial that was actually led here in Canada by Alexis Turgeon in Quebec City, and basically randomizing patients to a liberal strategy where you target up to a target of hemoglobin of 100 and a more restrictive, so that sort of the more classical target of 70. And although it didn't show a statistical difference in the risk of unfavorable outcome in 6 months, there was a direction of effect. If you look at the shifts in the GOAC range, seems to be favoring the liberal strategy, although for the statistical purist, the primary outcome still was not significant. That said, if you look at some of the secondary outcomes, including quality of life and functional independence measure, there seemed to be a benefit. So probably we shouldn't wait to transfuse this patient, for the hemoglobin to be 70, whether 80 is a better target or 100. I don't think this trial necessarily, gives us the answer, but I probably would personally be a little bit more liberal with transfusing these patients early on. Okay, so going back to the case, so as you remember, the patient had an ICP and a brain tissue oxygen monitor that was inserted. He had ICP spike to the mid-30s, and this was initially responsive to hyperosmolar therapy. So he was sedated on high-dose sedation. He was on propofol, ketamine, midaz, hydromorphone, and he was intermittently paralyzed. He even had one load of phenobarbital, and the repeat CT did not show any significant changes in that, big extraaxial hematoma that he had at the back of the brain. So there wasn't really a good reason to take the patient to the operating room. That said, he had a persistent intermittent high ICPs above 22. And, at some point, the brain tissue oxygen started drifting to less than 20. And so we talked with the neurosurgery team, and an EVD was inserted at around day 3 of his ICU stay. And post EVD insertion, the ICP went from the 30s to the mid-teens, and his PB2 to almost double, from 17 to 35, and then we were able to, slowly win the sedation. And for the ultrasound geeks among us, and I'm not one of them, but you can look at this very beautiful TCD done by Marina, was one of our previous fellows in TNICU. And you can see that above you have the big systolic spikes prior to the EVD being inserted, which basically reflects very low brain compliance. And then if you look at the graph, if you look at the tracing in the bottom, you can see that you see a bit more of a diastolic waveform after the EVD insertion. So this is a very good example that, by, a simple intervention, just draining a few cc's of CSF, you can really shift the patient from an area of low brain compliance to an area of acceptable brain compliance. So the patient, as I said, sedation was weaned. Unfortunately, developed a ventilator-associated pneumonia, which is not uncommon for these patients, and then had a trach down on ICU day 14. Any questions about that? Okay, so I do want to talk a little bit about outcomes because I think historically we've had quite a pessimistic outlook in traumatic brain injury, and also prognostication is a big part of what we do on a day-to-day basis. So it's important to have some understanding of, how likely these patients are to do well or do poorly. And if you look at the most recent data that came from two very large observational study. One was track TBI in the US and the other one was center TBI in Europe, which I referred to before. About half of the patient with severe TBI or TBI that required ICU admission achieve independence at 12 months after injury. So 50%. So it's not, zero. And then 75% of patients with moderate TBI achieve functional independence. So majority. And even if you look at patients that were in a vegetative states at 2 weeks after the injury, 77% regained consciousness at some point in that same year, and 25% were fully oriented by 1 year. So this is quite humbling when you think about all the patients that, we try to prognosticate early on during their ICU stay, and probably we're getting it wrong a significant proportion of the time. And if you look at the data about withdrawal of life support, for example, in the center TBI study, more than half of the decisions were made to withdraw care within 72 hours of admission. And this is despite, consistent statement recommended we wait at least 72 hours. And based on what I told you, that's probably not enough time in many cases to pick up. If you have a truly devastating injury with, a a lot of bleeding in the brainstem, I think it's a different scenario. But for a lot of people, they're a bit more in a gray zone and probably need more time. So this is similar findings that they had in the track TBI studies of the American counterpart, and it really begs the question of whether early, withdrawal of life support is always justified or contributes to a self-fulfilling prophecy where people die early because they're not giving a reasonable chance to improve. If someone has very clear goals of care and they want to survive with any disability whatsoever, it's a different scenario. But often the patient, the family doesn't know, and we have to guide them. And I think it's very challenging because even the most extensively validated prognostic model, which are the impact based model and the crash trial based model, only really account for about 30% of the outcome. And you can Google them and put your patient information into the calculator, and it'll give you a probability of mortality in percentage points for your patient. But the problem with these models is they rely on a very few sets of predictor derived from population averages, meaning that you have to be really careful about applying them to the individual patient in front of you. They're really more meant as a way of adjusting statistical analysis and research at a population level rather than a individual prognostication in a clinical setting. So there's a lot of work that's been done recently to try to improve and individualize outcome prediction, and not only looking at advanced neuroimaging features, but things like serum biomarkers, genomics, neurophysiological data, and other clinical variables. And I think ultimately we'll probably need a combination of all of these different things and better integrated to reliably prognosticate in these patients. So just to finish the case, so the patient started obeying commands about ICU day 20 and was mouthing words. He was transferred to the floor day 26, discharged to rehab at 3 months. At that stage, he was GCS 15. He was alert and oriented and slowly recovered some right-sided strength and was ambulating with a two-wheel walker. And I wasn't the one following with up in clinic, but I heard that he was doing quite well despite all of this. So just some take-home messages. So I think TBI is a very common problem, and it's one of the leading cause of morbidity and mortality in young people in Canada, but also in developing countries. You do want to avoid hypertension, hypoxia at all costs, but also don't forget about the CO2. And you should be familiar with the guidelines, but there's some ways that maybe we can individualize our treatment targets a little bit better using monitoring and other tools. And we do want to be cautious about prognosticating too early. And I said I wouldn't talk about prevention, but I lied. And this is our daughter when she was starting to walk a couple months ago. So we got her this little butterfly backpack. So I think it saved her from banging her head a floor a few times, but now she sort of ditched it and started running all over the place. So I think the next thing she'll be biking around her, and I'll have to be worried. So seemingly benign intervention or not without side effects also. And you can see that here she's getting stuck under the chair from the little backpack, and she's getting very frustrated. So I think that's all I have to say for the TBI part. And please, if you have any question, stick around and ask me. And this is my email if you're too shy to ask in front of everyone. I do have a few slides on spinal cord injury. I do realize that I've talked for a long time and it's 3:30. So I think we should postpone this to another session unless you guys there's anyone that, really want to hear about this. Any preference? I'm gonna assume no, because I You guys are probably too polite to say it, but if anyone wants to hear about it, let me know, and I'm happy to give you the talk privately. No questions? Okay. Well, in that case, I think I'll let you guys go a little bit early. And yeah, please feel free to email me if you have any questions. I'm always happy to answer.